So I guess I want to say, whew, we did it. Many, many thanks to all of our panelists for saying so much in such limited time, and I hope that we have 30 minutes allotted, so we have a lot of time to expand on points and discuss back and forth some of the issues that we had to go quickly over, but I know you want to know more about. I want to just ask folks if they can start coming to the sides of the room where the microphones are. When you pose your question or comment, please make sure you state your name and your organization. And I'm going to keep an eye on the two Amy's because, of course, we want to have those of you online to be our Twitter questions. So wave as they come in. But please, folks out there in the web, please send us your questions. I also want to make sure that we do give the Spitali family an opportunity, if they would like, to ask some questions of the panel. We'll have a microphone if you do, or you want to just wait and watch? Yeah. Frank? Okay. Not a problem. Wave if you need this. So without further ado, I think we're going to start with a Twitter question. Amy.
An excellent panel. We have I'm Amy Berman from the John A. Hartford Foundation, and our question is from Reverend Amy Zeitlau, who is a Lutheran minister, former COO of a hospice in Baton Rouge, and a chaplain, and who also does, she is a scholar in family caregiving. And her question is, how might Family Medical Leave Act benefit, be of help or support to the seriously ill?
So the Family Medical Leave Act, the Paid Family Medical Leave Act, the national one has a 12-week limit, so it's a very limited benefit. But I think one of the things that it's been shown to do, at least in the California case, is it has actually reduced entry into nursing homes for people with serious illness. So there's some early evidence that it's helping people remain at home for longer just by having that 12-week break. So it can really help caregivers perhaps recharge or take care of themselves during that time and not be juggling those work duties and caregiving duties. Other ideas from panelists?
As somebody who was fortunate enough to access that, I was lucky in that my particular employer allowed me to do that in pieces rather than all or none. So, and that flexibility allowed me to use it when I absolutely couldn't work and not have to have it when I could find ways to work. The other thing that I think is helpful if you're lucky enough to have the type of position that you can do some work at home, if employers are able to allow us to do distant kind of work in those kind of positions, that's helpful. But I think if you're an employee at Walmart and you're punching a clock and you're trying to attend doctor's appointments and clinics and be there when they're in the hospital and those kinds of things, that act is not enough. It does not go far enough, and those are the people that earn the least amount of money and probably need it the most. And so it's better than nothing, and it can be helpful, but I think we got a long way to go.
Let's move to the microphones, sir.
Hi, yes. My name is Will Blesser. I'm with Duke University's Margolis Center for Health Policy. So we have a grant we're working on to look at how ACOs can improve the care of people with serious illness. And that includes caregivers. And I'm thinking about this presentation and the one before. And one of the key mechanisms for why ACOs can help this space is their care coordination, their focus on care coordination and contracting with a lot of different partners. I'm thinking about extended partnerships, in the community. And especially from the previous session, if it's not that, if we shouldn't be doing it through the healthcare lens, how can ACOs work, even if not contractually, or how can we encourage them to work with, whether formally or contracted or not contracted, with extended community members more efficiently to deliver these services in a more efficient way?
So thank you for your question. I think this is an emerging and very important area. And it's complex because of the issue that's been raised earlier about families not currently being visible within systems of care. So I think beginning potentially with a target population of individuals with serious illness and then making a concerted effort to developing systems, data management systems, data capture systems, so that you have structured fields to be able to assess not just whether there's a family member present, but who that family member is. And then starting to wrap around services. We heard earlier about case management services, starting to wrap around services so that it's possible to understand not just who they are, but how are they functioning? Do they have the capacity to provide care? What are the challenges they're experiencing? And then beginning to build out services to support not just individuals with serious illness, but the families who are often integral in the care, managing care, coordinating care. And that would move the needle in terms of being able to describe who's being served so we can move beyond the kinds of data that's so important that Dr. Schultz presented from national data sets, but thinking about contemporary information that allows intervention in a real-time way.
Let's take a question from this.
My name is it on? Okay. My name is Chow. I'm a commissioner of the Montgomery County Commission on Aging, but my real volunteer work is with the Vietnamese Senior Association of Long Branch. These are the former refugees from Southeast Asia that came in a large group in 1974. I would like to do two things. The first thing is I have been looking out to hear the issue of language facility or lack of thereof, the LEP. And the second one is the effect of culture as an interference with all these caregiving places. The first thing that I'd like to do, though, is to add the post-traumatic syndrome to the list of serious illness. I know it is serious because I am a PTSD case. And the people that I work with, from what I can see, look like walking trees, as we say in Vietnamese, of PTSDs. The problem, and by the way, I was both enlightened and intimidated by all these professional presentations. I was schooled at Mount Holyoke, the University of Michigan Social Research, and the Graduate School of Business of Columbia University. And in that report, I would like to say that whenever I stepped in with a local host hospital trying to help an LEP member of my group, and I was told, take that person to the language line. We don't want to deal with you. I couldn't offer my help. I hope my English is understandable, but that's what I was told. They refused to let me go through and help the person. The second thing is when I mentioned that I had PTSD, people kind of recoiled. They didn't want to discuss that, both in a government context, because I know services are limited and all of that, I understand. But the other side, even in private business, when I attended a meeting, they wanted to give an award for people who brought out these problems, but they did not want to discuss PTSD. I'd like this group to explain to me how to understand. The most serious issue is we're talking about care providers and community-based organizations. There's a problem that I have encountered when the first arrival of the refugees was that if you had a child in a family that spoke English, the child became the boss because he or she spoke English. The same thing now, unfortunately, is happening with community-based organizations. These are people who can afford to speak English, but they do not have the knowledge that you all are talking about. So whenever the family cannot be a caregiver as such, but whenever a sufferer or a family wants to come forward and talk about the problem, the English-speaking person tends to anticipate the reactions of the world out there in terms of available assistance programs. They refuse to let it go forward. My basic question, not real, my basic question is, to what extent have you been able to bring out the actual inputs of the sufferers, and what kinds of methods are there, and can we propagate them so other people can profit from that? Thank you.
Panel.
You made a lot of amazingly important points, and I wanted to speak to one of them, which is the idea of trying to support people with PTSD. And it's hugely brave, and also I'm hugely sorry to hear that people didn't want to hear about your experience with PTSD. In the VA healthcare system, I'm at Duke and the VA, we do a lot of interventions, and the VA has a huge caregiver support program that serves people with PTSD. And we found a lot of things that we need to do to tailor the caregiver supports for them, because they don't like to come into the medical center. It's very triggering. They prefer modes of care that are more online supports through apps. Of course, they're younger too, the younger generations of people who have high rates of PTSD from recent conflicts, but also they want to have peer support and also kind of phone-based supports. So there are modes of delivery, how we need to reach caregivers to better support them when they have PTSD. And I think that's true of people with serious mental illness too. And I know other colleagues in the room have done work in this area. But in terms of cultural competency, maybe others have something to add.
Yeah, let me speak to the language and cultural competency issues. As Jennifer mentioned, there are a number of interventions that have been trialed in randomized trials that have been demonstrated to be relatively effective. And many of those interventions have now been translated, adapted to a variety of different populations and shown to be effective. In fact, some of the major interventions developed in the U.S. for family caregivers are now very popular in places like South Korea, China, Germany, and so on. So we do have some of the tools and strategies for addressing caregiver needs, and we have evidence showing that they can be reasonably easily translated and applied to populations beyond whites, which they are typically, which is where they typically start out.
I just want to add one more thing. First of all, hello, sister. I went to Mount Holyoke too, so it's always good to meet another sister in the room. I love that. That's great. We should talk later on that. But I just wanted to lift up that we hear this a lot from home care, direct care workers as well, the lack of cultural competency and language access. And so, in fact, we are requested all the time for more training. Like there's major training needs around caring for people with serious illness, and then there's training needs around cultural competency and how to actually manage language issues that come up. So it is a real arena that I think we do need to spend more time understanding. And I'll just say from my personal experience, the cultural competency piece is huge. I mean, my father has Alzheimer's, and the journey that me and my siblings and my mom had to go through in our community to get people to admit, and my father's a retired physician, by the way, right? To get our community to actually admit that he has Alzheimer's and then to actually address it is huge. And I think we're on the brink, given the diversity of our nation, we're on the brink of needing to really come up with a lot more strategies of how we're really engaging communities, diverse communities, in the conversations around cognitive illnesses and other serious illnesses. We can no longer afford to sort of downplay that. It's not a one size fits all, and therefore we really need the engagement of community members directly, people directly impacted in these issues, to help shape what we need moving forward.
Let's go to a question here.
Hi, my name is Amy York, and I'm with the Elder Care Workforce Alliance. We're a coalition of many organizations many are in the room, and Caring Across Generations is a member as well on the panel. And I appreciated the conversation about workforce. Obviously, that is our focus, but we also have a focus on caregiving. And Sarita, you mentioned training, and I think it's important to remember that that we need training across all of these sectors of care, the caregivers, the social care side, as well as the medical care side, and training on how do we talk to caregivers, how do we support their needs, and I think much in the way of we've had this discussion about end of life issues and having those discussions. I think we need to start having those that type of training for this care team as well. And I just am curious if you know of things that are already happening or things that you think we need to be doing in this area. Thanks.
Well, I'll definitely share. Thank you, Amy, and thanks for all the work that you do. It's so important. I would just say, I think you know as much as I do some of the existing models that exist. We've certainly looked at models from Washington State in particular, which has one of the strongest models of training direct care workers and caregivers, to your point of like the kind of training across the spectrum, but also the integration. We're starting to get into the conversations about integrating with the broader health system. I actually think one of the things we really need right now is as more states are beginning to explore this question, we actually need a lot more incentives for states to really figure out, I think it'd be great if the federal government actually created innovation sort of funds for states to really think about the workforce, the needs, the kinds of training, the diversity of trainings. A lot of what we hear is it's not helpful to have just in-person trainings, online trainings, language access to trainings, et cetera. So I feel like there's an opportunity right now at the state level to dive into these questions and begin to pilot and model. And others may be aware on the panel of efforts underway. I know in Maryland, I'm about to dive into a process there, which I'm really excited about. But I think we need to document these pilots that people are beginning to develop so that we can sort of pull out the best practices. But that would be one. I mean, we need to incentivize this seriously.
Go to Twitter.
Great, thank you. First, a late-breaking announcement. The hashtag Serious Illness Care NASEM is now trending on Twitter. So thank you, everyone in the audience, both here in the room and also online. We are number 9 on Twitter, and I know all the passion and dedication in this room. We can even do better than that. So keep tweeting. But the question is from Denise Hess, Executive Director of the Supportive Care Coalition. She wants to know, in light of Marianne Spitali's mention of her resource connections at her church, are the panelists aware of any best practice examples utilizing faith community partnerships to address family caregiver needs?
I'm aware of a few. Actually, last year I attended the End Well conference, and there was a fabulous panelist who is a faith leader. And so I feel like in Northern California, I've seen some really good models of where the faith community has really understood that they're on the front lines of talking to families and supporting families through this journey, and have really taken that role on seriously. So there are faith networks that are out there that are doing this work. I just don't know enough of the details of what those projects are, but they do exist. I don't know if others have.
I bet Marian might say something, so hold on, and I'm going to switch to here, but perhaps the CTAC initiative would be a great thing to talk about with faith-based communities. Kathy.
Kathy Greenlee, former Assistant Secretary for Aging. Caregiving is always such a compelling issue. I want to add something else that's hard and always hard to bring up here. But, for older people who were abused, the person most likely to abuse them is their caregiver. And it's always hard to bring that up because caregiving is such a compelling issue that we all really want to support caregivers. But I think we have to name it. And I think it has to be part of the assessment of a caregiver because there are known risk factors: caregiver depression, caregiver who needs treatment, a care recipient who is combative or resistive to care. Because I think the best public policy and I think the best programs for prevention have to be informed by people from the caregiving community who pull out this very horrible outcome and help us address it by saying, let's prioritize, let's give education, let's give support, and let's get upstream of this terrible problem, because it is the ultimate failure. And if you and everybody working on caregiving don't bring it to the table, then we don't have the experts that we need to try to address it so that we can make it a better situation for the care recipient and the caregiver as well.
Thank you so much for reminding us of this. Marian.
So, thank you. I'm Marian Grant. I'm a policy consultant for the Coalition to Transform Advanced Care, which has for years worked with communities on faith-based efforts for serious illness, both for patients and for families. These are very local experiences. They take a lot of effort and they take a lot of resources. Many communities don't have those resources, but that is certainly an appropriate place to look for a partnership because many people are part of a faith community. Faith leaders are often asked about what to do about serious illness, important decisions. They have congregants who are caregivers. They see the struggle. So it's kind of a natural interface, and yet it's not easy for the health system and the faith community to kind of work together, but they can under certain circumstances. I was going to ask I'm hoping a simple question, and that is that in addition to my policy work, I am a practicing palliative care nurse practitioner. I will be working tomorrow in my hospital. And I am valiantly, as I know other clinicians here, trying to get the world of the EHR to include a person's healthcare power of attorney. I cannot tell you how many family meetings I go to that turn out not to have that person present who should be making important decisions. But I also, as a clinician, recognize that there's a whole other group of people who are the caregivers. That is not always the same person, right? So I just recently met a patient whose daughter was the healthcare power of attorney, but whose wife is his day-to-day caregiver. I totally respect that, and yet I have to say I don't know a good way to capture that information, first of all, in the chart, and second of all, I don't think we as clinicians know what to do about that information. So like who are we going to call? And I didn't know if anybody had struggled with the same thing and had any advice or update on are EHRs adding both pieces of information? No. Okay. So my hospital is, once again, not unique.
I know that as I've talked to people around the country about my experience, I always hear this, well, the one reason we don't really assess caregivers is because we don't know what to do with the information once we get it. And that's not my patient. They might be somebody else's patient, and I can't take care of them if there's somebody else. I mean, I get lots of things, but the EMR is always one of those reasons that we're given. And it's just something we've got to figure out.
So thank you for your important question. I know at my institution, Johns Hopkins Medical Institutions, there's been a lot of effort in trying to improve the documentation of this information in the electronic health record with more visible tabs to indicate when information is in the electronic health record so it's not lost in unmarked attachments. I would also say that my colleagues tell me that there are advances coming down the pike where there's a shift towards more allowing more patient-generated health data, including uploading attachments themselves. So this is another important strategy that could be used so that often patients do have advanced directives that they complete with an attorney, for example, so allowing them to be able to upload that information. And I would say another important issue that I've given a lot of thought about is the information access for patients patients' families, so that patients' families have their own identity credentials to be able to access patients' health information. And most health systems do have the capacity to allow patients to share access to their electronic health information with families. Patients often want this, but there's a lack of awareness among the medical community that this exists. There's a lack of awareness among patients and families. There also are cumbersome registration procedures for allowing families to have their own identity credentials. But as the electronic health record advances to allow patient-generated health data, that also sets the stage for families generated health data and being able to upload this information so that it's more accessible to health professionals, but also to families. So families can legitimately say, this information is there, I know it's there.
So I am so grateful that we had 30 minutes allotted to this session. Thank you, Judy and Joanne, for that. We've really reached the end of our half hour, and I hope that we can have a combined thank you once again for what has really been an excellent panel.